Here we have a known case of idiopathic pulmonary fibrosis in male 79 years old. Let's revise the findings without being biased by the clinical diagnosis, which was reached by biopsy. As a start of every interstitial lung disease, we first decide this case is fibrosing interstitial lung disease or non-fibrosing interstitial lung disease. According to what we saw now, we have fibrosing interstitial lung disease. Second step, we check for the criteria of pulmonary fibrosis. We start by checking the pattern of UIP, if it is present or not, and we try to place the pattern into one of the four categories. Here we have, as you can see, we have honeycombing at the periphery of the lung, subpleural location, irregular reticulation, and traction bronchiectasis. We go downward, the regular articulation is still seen with traction bronchiectasis. These are different from honeycombing. This is the honeycomb cyst, contiguous to each other and stacked to the costal margin. These are regular articulation with traction bronchiectasis. Traction bronchiectasis is a mimicker for honeycombing, and differentiation sometimes is hard, so we can use another tools of assessment in coronal reformat and sagittal reformat, and also in minimum intensity projection to see the continuity. As here, the traction bronchiectasis, you will see it nicely in minimum intensity projection as a continuation of the bronchiectasis. Differentiation is important because in case of no bronchocentric fibrosis, as we can appreciate here, mostly bronchocentric fibrosis is not there along the bronchovascular bundles. There is no the three triad of the bronchocentric fibrosis, irregular reticulation, ground glass, and traction bronchiectasis. According to this definition, this is no bronchocentric fibrosis, only traction bronchiectasis, unavailable ground glass, unavailable irregular reticulation. So we have confined subpleural, peripheral, epicobasal with epicobasal gradient, honeycombing, irregular reticulation, traction bronchiectasis, traction bronchiectasis. Here on the lung basis, you can see nicely how we have the honeycomb cysts. At lung basis, this will differentiate between typical UIP and probable UIP. And the role of radiologist to mention in report the typical UIP, not to mention its idiopathic pulmonary fibrosis, because this can happen as a consequent to connective tissue disease. It can be secondary to rheumatoid arthritis, for example, not an idiopathic pulmonary fibrosis. Clinician role is to exclude the connective tissue disease and others to reach the diagnosis of IPF according to the HRCT picture of typical UIP, which in near future, and most of the institutes now are sufficiently diagnose IPF by clinical exclusion of other entities and no need to undergo a biopsy. And thanks for your attention.